So you know that exact feeling. It is 7 p.m. on a Sunday. You're sitting at the fellow's desk, sipping that lukewarm, stale coffee, and you are just staring down tomorrow's endoscopy schedule.
Yeah, that Sunday night dread. We all know it.
Right. And your third patient of the day is on blood thinners. And instantly, I mean, the questions just start spiraling in your head. Do you hold the medication? When do you stop it? Do they need a bridge?
Because, you suddenly realize the training wheels are off. This isn't just some administrative checklist anymore.
Exactly. If you get this wrong in one direction, they hemorrhage right there on your table. But if you calculate it wrong the other way, they throw a massive clot in the recovery room.
It's basically the ultimate clinical tightrope walk. And honestly, it's a scenario where your gut feeling or just clinical intuition is totally going to fail you.
Which is exactly why we were dedicating this entire deep dive to you. You, the first-year GI fellow. First of all, congratulations on starting your fellowship.
Yes, welcome to the trenches.
Take a deep breath, because today we are handing you the compass for this exact clinical nightmare. We are drawing entirely from the foundational lectures by Dr. Gautamukula S. Raju, his step-by-step guides on the perioperative management of antithrombotics for endoscopy.
I mean, these lectures are the gold standard. Dr. Raju's genius here is that he doesn't just, hand you a cheat sheet of drug hold times.
Right, because cheat sheets get lost or outdated.
Exactly. He forces you to understand the underlying mechanics. When you grasp the pharmacokinetic clocks and the actual pathological risks at the same time, you're not just memorizing guidelines, you are practicing true precision medicine.
So let's unpack this, because as a new fellow, mastering this balance is going to be your absolute bread and butter. The first mistake we always make on that Sunday night is treating the phrase high risk like it's some subjective adjective.
Right, like, oh, they have a heart valve. Yeah, that seems high risk.
Yeah, but using Dr. Raju's framework, we have to treat risk like a strict mathematical equation. So let's look at the clot side of the scale first, the thrombotic risk.
The math here is absolute. When we say a patient has a high thrombotic risk, we literally mean they have a greater than 10% chance of an arterial event per year.
Okay, so 10% is the magic number.
Yes. Or if we are talking about venous events, a greater than 10% chance per month. That's the threshold. Moderate risk is between 4 and 10%, and low risk is anything under 4%.
Got it. So we need to stratify our patients into those specific buckets. Let's tackle arterial risk first. So blood pumping away from the heart. My assumption, just looking at a chart, is that any hardware in the heart is an automatic red alert.
Yeah, that's what everyone thinks at first.
Right. Like if they have a standard bileaflet aortic valve, I'm immediately putting them in that greater than 10% bucket.
Well, actually, that's a really common trap for new fellows. Hardware does not universally equal high risk.
Wait, really? A mechanical valve is default low risk?
Yes, by default. Because bileaflet aortic valves, just because of their design, they promote relatively laminar blood flow. They don't generate the extreme turbulence that violently activates platelets.
Oh, wow. Okay, so a solitary bileaflet aortic valve is low risk.
But, and this is a massive caveat, it remains low risk only if they have absolutely zero other stroke risk factors.
Ah, I see. So what happens if they do?
If you take that exact same patient with the bileaflet valve and add a comorbidity like hypertension, diabetes, congestive heart failure, or, older age or a prior stroke, the whole hemodynamic environment shifts.
Right, you get endothelial dysfunction.
Exactly, and that bumps them instantly from low to moderate risk.
That completely changes how you review a chart. You
Okay.
can't just isolate the cardiac history. You have to look at the entire systemic environment. So what kind of valve actually is an automatic high-risk trigger then?
Caged ball valves and tilting disc valves, particularly in the mitral position.
Just because they're older designs.
Yeah, those older mechanical designs cause severe shear stress and turbulence. If you see a caged ball valve in the history, you don't even need to look at the rest of the chart. They are mathematically high risk for an arterial event.
Okay, that makes sense. Let's pivot to something you see on like every other chart. Atrial fibrillation. I mean, AFib is so ubiquitous it almost blends into the background noise.
Which is exactly why you have to rigorously apply the CHA2DS2 VASC score.
Yeah.
Not every AFib patient is carrying the same thromboembolic potential.
So remind us of the breakdown there.
If you calculate their score and it's greater than 7, they cross that 10% threshold. They are high risk.
Okay, greater than 7 is high.
Right. A score of 5 to 6 puts them in moderate risk, and 1 to 4 keeps them in the low risk category.
Let's take that a step further, though, because scores are great, but are there any clinical trapdoors? Say I have a patient with AFib. Their score is only a 3. Normally, that's low risk. But I see in their neuronotes they had a TIA about 8 weeks ago. Does the low score protect them?
No, absolutely not. The recent TIA entirely overrides the score.
Oh, wow. Just immediately.
Instantly. There are two instant high-risk triggers in the context of AFib that bypass that calculation completely. The first is rheumatic valvular heart disease, and the second, like you just said, is a recent stroke, or TIA.
And what defines recent in this context?
Strictly within the last 3 months.
Is that because the endothelium hasn't stabilized yet?
Precisely. The vascular bed is highly reactive. The presence of a stroke or TIA within that 90-day window pushes the risk well past the 10% annual threshold, regardless of how young or healthy the patient might otherwise score.
Okay, so that covers the arterial side. We're mapping the turbulence in the hardware. Let's flip over to the venous side. Venous thromboembolism, DVTs and PEs. Dr. Raju's material makes a big point that on the venous side, the calendar is basically your primary diagnostic tool.
Yeah, time is the dominant variable in VTE risk assessment because it literally dictates the physical organization of the clot.
So walk me through the timeline.
If a patient had a DVT or PE in the last 3 months, they are categorized as high risk. But if that event occurred within the last 30 days,
They escalate to ultra-high risk.
exactly, their chance of recurrent thrombosis is greater than 10% per month, not per year, per month.
Let's talk about the physiology of that timeline, just so it sticks.
Yeah.
Why is the 3-month mark the magic cutoff where risk starts to downgrade?
Well, it takes roughly 3 months for a venous thrombus to fully organize, for the fibrin to cross-link densely, and for endothelialization to occur right over the surface of the clot.
But the body is basically walling it off from the active circulation.
Right. Before that 90-day mark, the clot is friable. It's actively shedding procoagulant factors, and the systemic inflammatory response is just driving this huge hypercoagulability.
So less than 3 months is high risk. 3 to 12 months, as the body kind of remodels the vessel, is moderate risk. And an event more than a year ago is low risk.
You got it.
But just like the arterial side has that TIA trapdoor we talked about, the venous side has to have underlying pathologies that just hijack this calendar, right?
Well, definitely. Severe thrombophilias will render that timeline totally obsolete. We are looking for genetic blueprints that just scream hypercoagulability.
Like protein C or S deficiency.
Yeah, protein C, protein S deficiency, antithrombin deficiency, factor V Leiden, prothrombin gene mutations, or, and this heavily compounds the issue, patients who are double heterozygous for multiple mutations.
Which means they have a severe inherited defect in their natural anticoagulant pathways.
Right.
So you don't wait for them to have a massive PE to treat them as high risk.
No, absolutely not. If they have antiphospholipid syndrome or a severe thrombophilia, they just live in the high-risk bucket forever.
But there's another underlying pathology here that I think is honestly the most critical takeaway for our listeners. Let's talk about oncology.
This is huge for GI fellows. Active cancer or cancer diagnosed within the last 5 years is inherently prothrombotic.
Right. Cancer causes clotting. We know that.
But the guidelines specifically isolate certain malignancies as definitively high risk for VTE. Myeloproliferative neoplasms, brain tumors, and specifically esophageal, pancreatic, and gastric cancers.
I mean, the irony here is thick. You are a GI fellow. You literally spend your days hunting for esophageal, pancreatic, and gastric pathology.
Exactly.
Or diagnosing the very diseases that will radically spike the patient's risk of clotting on your table. Why are these specific upper GI cancers so fiercely prothrombotic compared to, say, a localized colon cancer?
It really comes down to tumor biology.
Yeah.
Gastric and pancreatic tumors in particular are notorious for secreting massive amounts of tissue factor and these highly procoagulant mucins directly into the systemic circulation.
So it's not just a mass sitting there.
No, it's essentially an endocrine organ. It's constantly dripping chemical triggers that inappropriately activate factor X and the broader coagulation cascade. It's classic Trousseau syndrome physiology.
That changes the lens completely. I mean, if you're doing a routine screening colonoscopy on a 65-year-old who had a partial gastrectomy for gastric cancer like 4 years ago, you cannot just treat them as a routine low-risk, lower GI scope.
Absolutely not. Their systemic biology is still primed to clot. You have to treat them as high risk for a venous thromboembolism.
So other cancers place the patient at moderate risk, and non-melanoma skin cancers are excluded entirely. But those upper GI and pancreatic tumors, they demand extreme caution.
Yes, always be hyper aware of those.
Okay, so we have our thrombotic risk dialed in. We know who is going to clot if we stop their blood thinners. Now we have to analyze the counterweight. procedural bleeding risk.
Right, the other side of the coin.
And as a GI fellow, this requires visualizing the microanatomy of the gut wall.
Bleeding risk isn't about the size of the instrument you're using. It is entirely about the anatomical depth of your intervention.
Let's break down the layers.
You have the mucosal layer on the surface, the submucosa beneath it, the muscularis propria, and the serosa. The submucosa is the critical zone. That is where the major arterial and venous plexuses reside.
Okay, so let's categorize our procedures based on that depth. If I'm doing a purely diagnostic EGD, I'm just taking a look at a suspected stricture. I don't deploy forceps, I don't cut anything. What is the risk?
Minimal. It is essentially a 0% bleeding risk. As long as you are navigating the lumen safely, you aren't disrupting that vascular architecture at all.
Okay, let's step it up a bit. A standard colonoscopy, where I take several cold forceps biopsies of the mucosa to check for, say, microscopic colitis. This falls into the low to moderate risk bucket, right? Like a 0 to 2% chance of a major bleed.
Yes, exactly.
Why doesn't ripping pieces of tissue off the colon wall cause a massive bleed? I mean, to a layperson, that sounds violent.
Because you are restricting your trauma to the superficial mucosa. The mucosal capillary beds are small and they are highly responsive.
So they just clamp down.
Basically, yeah. When you take a standard biopsy, those tiny vessels spasm and the local coagulation cascade can easily plug those microdefects. You aren't breaching the submucosal plane where the larger high-pressure vessels live.
I like to think of it like scraping the icing off a cake. The big, dangerous blood vessels are deeper down in the cake layer in the submucosa, so superficial icing biopsies are generally safe.
That's a great analogy, but when we move to high-risk procedures where the bleeding risk jumps significantly above 2%, we are intentionally invading that submucosal cake layer.
Right. So we are talking about polypectomy, endoscopic mucosal resection, EMR, endoscopic submucosal dissection, ESD-ERCP with sphincterotomy, uncontrolled stricture dilation, and PEG tube placement.
Yeah, and ESD literally involves excavating tissue out of the submucosal space. You are carving right through the neighborhood where the major vessels live.
And a PEG placement is a literal full-thickness puncture.
Exactly. A sphincterotomy physically severs the muscle layer and its associated vascular supply. In all of these high-risk scenarios, you are creating a substantial, deep structural wound in a highly vascularized area.
So a mucosal biopsy might clot on its own in minutes, but a massive ESD ulcer leaves a raw, vulnerable vascular bed exposed for days, right?
Days. It requires complex mucosal healing.
This perfectly sets up that central conflict you face at your desk on Sunday night. You have a patient with a recent DVT who desperately needs a large lateral spreading tumor removed via EMR. High clot risk, high bleed risk.
You can't just flip a coin.
Right. You have to actively manipulate these risks using the pharmacokinetics of the drugs themselves.
This is where we move from risk stratification into actual pharmacological strategy. To control the situation, you have to weaponize the internal clocks of the antithrombotic medication.
Okay, weaponize the clocks. I like that.
You need the drug entirely out of the vascular system the precise moment you resect the polyp, and you need it flooding back in the exact moment the mucosal ulcer stabilizes.
Dr. Raju breaks this down into two immutable laws. The half-life rule, which dictates when we stop the drug, and the peak action rule, which dictates when we restart it. Let's dive into the half-life rule first.
The pharmacological principle here is pretty standard. It takes roughly 4 to 5 elimination half-lives for a drug's systemic concentration to degrade to a level that is clinically insignificant.
Meaning it's safe enough to perform an invasive procedure, dropping from 50% to 25 to 12.5 and so on.
Correct.
Let's map out the speeds of our most common drugs. If you want a drug out of the system quickly, you reach for unfractionated heparin.
Unfractionated heparin is incredibly rapid. Its elimination half-life is between 30 to 60 minutes.
So if you shut off an IV heparin drip within 4 to 5 hours, the drug is functionally cleared from the bloodstream.
Exactly. It's the sports car of anticoagulants.
Next down the line is low molecular weight heparin, like enoxaparin.
Its half-life extends to about 3 to 4 hours, so still very fast, but requires a bit more planning than the drip.
Then we hit the direct oral anticoagulants, the DOACs, apixaban, rivaroxaban.
The DOACs generally possess a half-life of 9 to 14 hours in a patient with healthy renal function. This means you need significantly more lead time to clear them.
And finally, the absolute slowest of the bunch, warfarin.
Warfarin has an immense elimination half-life of 36 to 42 hours.
Oh, wow.
Yeah, it takes almost 2 days just for the active concentration to drop by half. To achieve 4 to 5 half-lives for warfarin requires nearly a week.
Okay, so the half-life rule tells us when to pull the plug before we cut. The second law is the peak action rule. This is all about post-op management, right?
Yes.
So say you just performed a high-risk EMR. You left a massive 4-centimeter ulcer in the ascending colon. You need to restart their blood thinners to protect the mechanical valve. But you have to know how fast the drug is going to hit maximum velocity.
Because the goal is to perfectly avoid overlapping maximum therapeutic anticoagulation with the most fragile phase of the procedure-induced wound.
So how fast are the DOACs?
DOACs and low molecular weight heparins hit their peak therapeutic effect incredibly fast, usually within 2 to 4 hours of oral ingestion or subcutaneous injection.
So if a patient swallows an apixaban pill in the recovery room, 180 minutes later, their blood is as thin as it will ever get.
Which is catastrophic if that 4-centimeter ulcer hasn't begun to form a stable, organized fibrin clot yet.
And warfarin, by contrast, is sluggish.
Extremely. Even when restarted, it takes days to plateau and reach its peak therapeutic INR.
So we have fast clearers and slow clearers, fast peakers and slow peakers. But before we build the actual step-by-step schedules for tomorrow's endoscopy list, there is a massive physiological roadblock that can ruin all of this math.
Ah, yes. The kidney caveat.
Right. And as you always say, if we connect this to the bigger picture, you can never forget internal medicine.
You ignore internal medicine at your own peril. Renal function dictates the pharmacokinetics of almost everything we just discussed.
Because if the glomerular filtration rate tanks, the half-life stretches. The drug gets trapped in the system. So which of these drugs are relatively safe to use in a patient with renal failure?
Unfractionated heparin and warfarin are primarily metabolized hepatically, or they just have minimal dependence on renal clearance. You can generally rely on their standard half-lives even in patients with severe chronic kidney disease.
But the others, low molecular weight heparin and the DOACs.
They are highly dependent on the kidneys for clearance. And Dr. Raju's source material singles out dabigatran as a particularly dangerous trap here.
Why dabigatran specifically?
Because roughly 80% of dabigatran is excreted unchanged by the kidneys.
80%. The clinical implication of that is massive. So if a patient's creatinine clearance drops below 50, dabigatran's half-life doesn't just bump up slightly, it practically doubles, right? Jumping from a normal 12 hours up to 18 to 24 hours.
Think about the math there. If the half-life is 24 hours and you need 4 to 5 half-lives to safely perform an EMR, you need to hold the drug for nearly 5 days. Wow.
If you apply the standard healthy kidney DOAC protocol to this patient, they will arrive in your endoscopy suite heavily anticoagulated. You will cut into the submucosa and they will not stop bleeding.
Check the EGFR. Always check the EGFR.
Always.
Okay, let's take all these pharmacokinetic laws and build the day-by-day playbook. Let's start with the DOACs apixaban, rivaroxaban, dabigatran, edoxaban. These are arguably the most common anticoagulants you'll encounter in outpatients.
They are incredibly popular because they don't require routine INR monitoring, but their rapid peak action makes them really unforgiving in the perioperative setting.
Let's run a scenario. Patient has normal renal function. They are on apixaban for AFib. You have them scheduled for a standard screening colonoscopy with a low to moderate bleeding risk. What is the hold protocol?
For a low or moderate risk procedure with normal kidneys, you stop the DOAC 1 day prior to the procedure.
Simple enough. What if that same patient is coming in for a high-risk procedure, say an ESD for an early gastric malignancy? The bleeding risk is high, so you need deeper clearance. You must stop the DOAC 2 days prior.
Let's translate this into a concrete calendar because medical day counting can be surprisingly confusing. Let's agree that the day of the procedure is always considered day 0. And obviously, they do not take a dose on the morning of day 0.
Correct. So if your high-risk ESD is scheduled for Friday is day 0, you need to stop the drug 2 days prior. They skip their dose on Thursday, which is day -1. They skip their dose on Wednesday, which is day -2.
So their absolute last dose of the DOAC is taken on Tuesday.
Exactly. Tuesday, last dose. Wednesday, skip. Thursday, skip. Friday, procedure. That provides roughly 60 to 72 hours of clearance, which comfortably covers the required 4 to 5 half-lives for a healthy kidney metabolizing apixaban.
By Friday morning, the systemic anticoagulant effect is negligible.
Right.
But let's apply the kidney caveat. I have a 72-year-old male on dabigatran. His creatinine clearance is 42. He needs a large colonic EMR, high bleeding risk.
Because the CRCL is below 50, that dabigatran half-life has doubled to 24 hours. The standard 2-day hold is dangerously insufficient. For a low-risk procedure in this patient, you must stop 2 days prior. But for your high-risk EMR, You must stop the dabigatran 4 days prior.
4 full days. So for a Friday procedure, they skipped Thursday, Wednesday, Tuesday, and Monday. Their last dose was on Sunday. That is a massive window of vulnerability for their AFib, which reinforces why risk stratification was so vital in our first step.
It forces you to balance the scales. Can this patient survive 5 days without dabigatran to safely allow for an EMR? If they have a high CHA2 DS2 VASC score, you are accepting a significant stroke risk to remove that polyp.
It's a tough call. All right, let's say the EMR is successful. You place a few clips, hemostasis looks excellent, the patient is in recovery. We have to navigate the peak action rule to restart the DOAC.
Remember, DOACs hit peak therapeutic velocity in 2 to 4 hours. You cannot give this drug until you are confident the wound can withstand maximal anticoagulation.
And Dr. Raju provides a brilliant, highly specific rule for this. Let's go back to our low risks scenario, a standard colonoscopy with some cold biopsies. You don't just write, resume DOAC tomorrow in the discharge paperwork.
Tomorrow is dangerously ambiguous. A patient might have their colonoscopy at 4 p.m., wake up the next day, and take their morning apixaban at 8 a.m.
That's only 16 hours of healing time.
Exactly. The mucosal defects haven't fully organized. The instruction must be precise. Wait exactly 24 hours.
So if the scope finishes at 4 p.m. on Friday, they take their restart dose at 4 p.m. on Saturday.
Yes. This guarantees a full diurnal cycle for the local coagulation cascade to seal the biopsy sites before the rapid 3-hour peak of the DOAC washes over them.
I love that precision. But what about our high-risk EMR patient? You just resected a massive lesion. A 24-hour wait seems, frankly, reckless.
It is. For high-risk procedures, EMR, ESD, sphincterotomy, you must withhold the DOAC for 48 to 72 hours post-procedure.
2 to 3 days post-op with no blood thinners.
It is the only way to allow the deep submucosal vessels to thrombose securely and for granulation tissue to begin forming. If you introduce a fast-peaking DOAC at hour 24, the high arterial pressure in the submucosa will simply blow out the fragile, immature clots, and the patient will present to the ER with a massive lower GI bleed.
Which brings us to the heavy machinery, warfarin. The logistics for DOACs are entirely dictated by their speed. Warfarin requires a completely inverted strategy because of its sheer lumbering mass.
The 36 to 42-hour half-life means you are maneuvering an oil tanker, not a speedboat. You have to start turning the wheel miles before you reach the port.
But first, an exception. If I'm performing a procedure with minimal bleeding risk, purely diagnostic, no biopsies, zero mucosal disruption, do I need to initiate this massive work-long process of pausing warfarin?
No. For purely diagnostic procedures, Dr. Raju notes you can simply continue the warfarin uninterrupted.
Really? Just scope right through it?
Yeah, the bleeding risk approaches zero, so disrupting a therapeutic INR is unnecessary clinical meddling. Just advance the scope gently.
But if we need to do a standard mucosal biopsy or a polypectomy, we have to pause. What is the standard warfarin hold protocol for a patient with low to moderate thrombotic risk?
You must pause warfarin 5 days before the procedure.
So if day 0 is the procedure, their last pill is on day -6.
Correct. Days -5, 4, 3, 2, and 1 are completely warfarin-free.
And what's happening biologically during those 5 days?
It allows the liver synthesis of vitamin K-dependent clotting factors, specifically factor 2, which has a 60-hour half-life to finally deplete, dropping the INR to a safe procedural level.
And restarting it. DOACs made us wait 48 to 72 hours because they peak so violently fast. Warfarin takes days to achieve a therapeutic INR.
Which turns its sluggishness into a distinct clinical advantage post-op. Because the peak action is so heavily delayed, you can safely restart warfarin on the evening of day 0, or at the latest, day 1.
Because it's not going to peak immediately anyway.
Right. The GI tract has several days to heal the surgical defects while the warfarin gradually ramps up systemic anticoagulation.
A slow fade out and a slow fade in. But let me throw a wrench into this. I have a 6-year-old male with a mechanical mitral valve, a tilting disc design. He also has AFib. He is presenting for a complex stricture dilation that carries a high bleeding risk.
He is mathematically at an ultra-high risk for an arterial clot.
Exactly. I absolutely cannot leave him unprotected for 5 days while we wait for the warfarin to clear. His valve will thrombose. But I also cannot dilate that stricture while his INR is 3.0. The submucosal will hemorrhage. How do we thread this needle?
This is the pinnacle of perioperative pharmacology. It's the art of bridging. What's fascinating here is how we use a fast-acting drug to surgically cover the vulnerable windows created by the slow-acting drug.
We are going to use low molecular weight heparin to build a bridge over the warfarin gap. Walk me through this day by day.
The anchor remains the same. You must stop the warfarin 5 days before. Last dose is on day -6.
Okay, the oil tanker is slowing down on day -5 and day -4.
You do nothing. The warfarin levels are dropping, but the INR is still therapeutically high enough to protect the mechanical valve. However, by day -3, the INR drops below the protective threshold. The patient is now critically vulnerable.
This is where we lay down the first plank of the bridge.
Yes. On day -3 and day -2, you administer a standard full therapeutic dose of subcutaneous LMWH. Remember, LMWH has a half-life of 3 to 4 hours and peaks rapidly. It instantly restores systemic anticoagulation to protect the valve while the warfarin continues to wash out.
So they are fully protected on days -3 and -2. But if they take a full dose of LMWH on day -1, won't they be at risk of bleeding on day 0? We establish LMWH is fast, but it still needs time to clear.
That is the crucial pivot point. On day -1, the day before the procedure, you administer exactly half of the LMWH dose.
Ah, clever.
Yeah, this reduced dose provides transient protection but ensures that by the morning of day 0, the fast-acting LMWH has completely cleared the systemic circulation.
That is pharmacological poetry right there. Warfarin stops day -6, wait 2 days, full LMWH day -3 and -2, half dose LMWH day -1.
Yeah.
By day 0 morning, the warfarin is entirely gone, the LMWH is burned off, and the patient's coagulation profile is functionally normal. You dilate the stricture safely.
The procedure is safe, but now you have a post-op crisis. You restart the warfarin on day 0 or day 1. But as we established, warfarin will take 4 to 5 days to reach a therapeutic INR. Your patient with the tilting disc valve is completely unprotected against a massive arterial stroke for nearly a week.
We need to build the bridge on the way back out. We need to use LMWH again while the warfarin slowly climbs. But wait. If I just dilated a massive stricture and I give them a full therapeutic dose of LMWH on post-op day 1, it's going to peak in 3 hours and they're going to bleed right into the lumen.
This requires aggressive dose modulation. You cannot hit them with a full therapeutic dose of LMWH while the surgical wound is fresh. For the first 2 to 3 days post-op, while the bleeding risk is critical, you utilize a low DVT prophylaxis dose of LMWH.
Something like enoxaparin 40 milligrams daily, or dalteparin 5,000 units.
Precisely. This subtherapeutic dose provides a baseline level of protection against thrombosis without aggressively challenging the newly formed mucosal clots. Once you are 48 to 72 hours out and the wound has stabilized, you escalate the LMWH back to the full therapeutic dose. You maintain that full LMWH bridge until the warfarin finally crosses the therapeutic INR threshold.
We are dynamically toggling the fast drug to cover the slow drug's blind spots, while simultaneously respecting the biological healing time of the GI tract. That is incredible. Okay, that covers our major anticoagulants. But there's a parallel universe of medications we have to manage. The antiplatelets.
Right, because anticoagulants disrupt the enzymatic clotting cascade proteins in the plasma. Antiplatelets function on a cellular level, physically preventing the platelets from aggregating and forming the initial primary hemostatic plug.
And to manage these, you have to understand the difference in receptor binding. We have drugs that cause permanent, irreversible inhibition and drugs that are reversible. Let's look at aspirin, clopidogrel, and prasugrel.
These agents bind irreversibly, often covalently, to the platelet receptors. When a molecule of clopidogrel binds to the P2Y12 receptor on a platelet, that specific receptor is permanently destroyed. The platelet is functionally disabled for the remainder of its lifespan.
And a platelet lives for exactly 10 days.
Correct. The megakaryocytes in the bone marrow are constantly producing new ones, but any platelet exposed to clopidogrel is permanently offline.
So if you stop the drug today, you still have a massive circulating pool of dead platelets. The anti-clotting effect lingers for over a week until the bone marrow mints enough fresh, naive platelets to restore hemostasis.
Contrast that mechanism with ticagrelor. Ticagrelor binds reversibly. It's an allosteric inhibitor. It temporarily occupies the receptor, preventing activation. But once the drug concentration in the plasma drops and it clears the system, it unbinds.
So the existing platelets just wake up and instantly resume normal function.
Exactly.
Okay, so permanent destruction versus a temporary nap. How does this dictate our hold times? Let's start with aspirin. There is a massive clinical divide here that every fellow needs tattooed on their brain.
It fundamentally depends on the indication. Secondary prophylaxis versus primary prophylaxis.
Right. So if my patient takes aspirin for secondary prophylaxis, meaning they have already suffered a myocardial infarction or an ischemic stroke, They're taking it specifically to prevent a recurrent event.
In the setting of secondary prophylaxis, you essentially never stop the aspirin. Even for high-risk endoscopic procedures with biopsies or resections, the aspirin continues uninterrupted.
Because the risk is just too high.
The catastrophic risk of inducing a recurrent MI or stroke vastly outweighs the nuisance of an endoscopically manageable mucosal bleed.
But if they're taking it for primary prevention, say a 65-year-old with no cardiac history who just takes a daily baby aspirin because his primary care doctor suggested it a decade ago for general cardiovascular health.
In primary prevention, the risk-benefit calculus flips entirely. The patient has never demonstrated an actual thrombotic phenotype. The risk of a severe procedural bleed during an EMR now outweighs the theoretical benefit of the daily aspirin. In this scenario, you safely hold the aspirin prior to the procedure.
Let's move to the heavier P2Y12 inhibitors. Knowing the 10-day lifespan of a platelet, what is the hold time for prasugrel?
Because prasugrel is an intensely potent, irreversible inhibitor, you must hold it for 7 to 10 days prior to a high-risk procedure. You literally have to wait for an entire generation of platelets to die off and be replaced by the bone marrow.
What about clopidogrel? Also irreversible, but slightly different kinetics, right?
The standard hold time for clopidogrel is 5 days.
Anticoagulant. Because it binds reversibly and doesn't require waiting for new platelet generation, the window should be tighter.
Ticagrelor requires a 3 to 5 day hold, and across the board, because antiplatelets do not have the violent 3-hour peak action of DOACs, you can typically safely restart them 1 day post-procedure once initial mucosal hemostasis is verified.
Okay, before we wrap, there is one last drug mentioned in Dr. Raju's materials. As a GI fellow, you will likely never write a prescription for this, but you absolutely will encounter it in the critical care setting, and it will terrify you if you don't understand its kinetics.
Ah, Cangrelor. It is the interventional cardiologist's secret weapon.
Why is Cangrelor so unique?
Its pharmacokinetic profile defies the typical rules we've discussed. Cangrelor is a reversible intravenous P2Y12 inhibitor that achieves peak therapeutic effect and subsequently washes out with an elimination half-life measured in 3 to 6 minutes.
Wait, minutes, not hours or days, minutes.
Minutes. You start the IV drip, and hemostasis is instantly paralyzed. You turn the drip off, and within 30 minutes, platelet function is completely 100% restored.
Wow. Picture the clinical scenario. It's 2 a.m. You are paged to the cardiac ICU for a massive upper GI bleed. The patient just had a complex left main coronary artery stent placed 48 hours ago. Cardiology is terrified that if the antiplatelets are stopped, the fresh stent will thrombose, leading to immediate cardiac death. You are terrified the patient will bleed to death from a massive duodenal ulcer if the platelets don't function.
It is the ultimate physiological standoff.
But if cardiology is running Cangrelor, they have an instant on-off switch. They can pause the infusion. 30 minutes later, you have normal platelet function. You endoscope the patient, deploy clips on the bleeding vessel, secure hemostasis, and back out.
And 5 minutes later, cardiology flips the switch back on, instantly protecting the fresh stent. As a GI fellow, you must know this drug exists so you can actively collaborate with the cardiology team to engineer these hyperacute, multidisciplinary bridges.
We have covered an immense landscape today. We've taken the panic out of that Sunday night schedule review. You now have the toolkit.
You now possess a mathematical framework to weigh the severe turbulence of mechanical valves and the procoagulant mucins of gastric cancers against the depth of your submucosal dissections.
You know exactly why renal failure forces a 4-day dabigatran hold, how to build a meticulously timed LMWH bridge for a slow-moving warfarin patient, and why a platelet's strict 10-day lifespan dictates the rules of prasugrel.
You are no longer guessing. You are applying the immutable laws of pharmacokinetics.
But I want to leave you with a final thought, something to push you slightly beyond this foundational framework. We've spent this entire session mapping out how to use time as our primary weapon. We rely on half-lives and biological decay.
But biology is inherently messy. What happens when you do the math perfectly? You hold the DOAC for exactly 4 days, but mid-procedure you encounter a massive, uncontrollable arterial bleed. The math fails, and you do not have 12 hours to wait for the remaining drug to clear.
It's exactly. As a first-year fellow, your next frontier is exploring the world of emergency reversal agents. How do we instantly shatter the pharmacokinetic rules? What is the molecular mechanism of edaratuzumab for dabigatran? How does andexanet alpha act as a decoy receptor to immediately neutralize apixaban?
That is where procedural GI intersects with acute emergency medicine.
Something to definitely mull over on your own. But for today, master the clocks, master the half-lives and the clearance rates. Thank you for joining us on this deep dive, and best of luck as you navigate your first year of fellowship. You have the tools. You've got this.